Apollo Hospitals. Today I'm going to present a short case. So, an 8-year-old child from Nizamabad who is studying 3rd standard, history given by father, who is a farmer by occupation. He studied up to 10th standard. Chief complaints: facial puffiness, leg swelling. It was persistent since last 2 months. History of present illness. As child had similar episodes in the past on and off, I would like to go back in the history to initial presentation. That is a 1 year ago in September 2022. Apparently, child was alright till then. Mother noticed sudden onset of swelling over the face, predominantly over the periorbital region, and progress associated with diurnal variation. Swelling is of non-painful, not associated with any redness. With above complaints, they consulted a nearby physician who ran some blood and urine investigations, and parents were told that child losing significant amount of protein in the urine. Father remember it as a 4+. Then child was started on prednisolone 1 tablet a day. Here on direct questioning, father denied any history of allergy in the past or febrile illness prior to the presentation. After a week of steroid course, as there was no improvement in child condition, parents took second opinion from another doctor, who escalated the dose to 4 tablets a day. Explained the need of continuous follow-up and prolonged course of steroid treatment. Parents were told to do home dipstick monitoring of the urine, and child responded to the treatment within the 10 days of the escalated dose, and swelling got reduced. After 3 to 4 weeks of the current course, steroid dose reduced to 3 tablets on alternate day. But within the 2 weeks time, again child started to have facial puffiness and there was increased proteinuria. Hence dose escalated back to 4 tablets per day. Second episode also responded to steroids and were able to change to alternate day regimen, but child developed relapse within the 10 days of change in regimen. Here on probing, there was no history of febrile illness, upper respiratory tract infection, or any drug incompliance. After the second relapse, child was referred to NIMS in February-March 2023. Upon consultation, dose escalated back to 4 tablets per day and advised some genetic tests. Details of the reports father unable to explain. For the next 3 months, they didn't come for follow-up. Urine tests were not done, but denied history of drug incompliance, and they were continued to use same dose of the medication for the past 3 months. In June-July 2023, again parents brought the child with history of generalized body swelling associated with breathing difficulty. Even for less than ordinary activities, she developed breathing difficulty, and there was history of reduced urine output for a day. And denied any history of fever or febrile illness. Here, child was treated with IV injections and 5 days of special injections presumed to be albumin. And with the treatment, child condition improved and was discharged with addition of the new oral medication advised to take twice a day. And there was no history of frequent blood tests following addition of the new drug. Even with the addition of the new medication, there was no complete improvement in the facial puffiness and leg swelling. Now, child was advised admission for the kidney biopsy. At present, she is having facial puffiness and distension of the abdomen, but not associated with fever, pain abdomen, and there was no complaints of the shortness of breath. In the past 1 year period, at any point of time, there was no history of glass hematuria, pain abdomen, hospital admission for fever, cough, burning micturition, and there was no history of drug incompliance. Parents did the dipstick examination only during the first month of the presentation. Later they didn't do. And at any point of time, creatine value, lipid profile, special test, they couldn't recollect. Child's perinatal and mother's obstetric history, it was not significant. And shall I elaborate now? She is the third born of non-consanguineous marriage, planned pregnancy, booked case, regular antenatal checkups were done, and USG scans were told to be normal. There was no history of infection or hypertension, poly or oligohydramnias during the antenatal checkup. Okay. So personal history, she is on mixed diet since last 1 year on salt restriction, achieved bowel bladder control. Past history, no history of asthma, allergy, seizure or TB contact. Family history, not significant. Drugs, currently she is taking prednisolone 1 tablet per day and 1 more tablet twice daily she is taking. Name of the tablet, father unable to tell. And calcium supplementation she is on. Occasionally she used to take antacids for the stomachache. Vaccination, mother says as per the government schedule, at Anganwadi center regular vaccinations were given till the 5 years of age. Allergy, so far none. Shall I summarize? A 8-year-old child, third born of non-consanguineous marriage without significant antenatal, postnatal or family history, presented 1 year ago with nephrotic syndrome, initially responded to steroids, relapsed twice while child was on alternative regimen. From third presentation onwards, in spite of the drug compliance, a full dose, child didn't attain any remission. In the June, fourth presentation with Anasarca was started on newer oral medication. Now, in view of persistent proteinuria, probably secondary steroid resistant nephrotic syndrome, planned for kidney biopsy and without any steroid toxicity. Nephrotic, childhood nephrotic syndrome and secondary steroid resistant nephrotic syndrome. Because initially she responded to steroids and we were
How can you rule out the possibility of an acute nephritic syndrome here
history
at the onset of the disease?
History-wise, they said only blood in protein in the urine. Regarding the blood, they didn't tell, and there is no
Clinically,
hypertension.
protein in the urine, only after urine analysis you will tell. Clinically, how can you say? Both will be
Hypertension.
preceded by an infection.
Hypertension, oliguria, these two things were not there.
Mm.
So,
Oliguria can be there in nephrotic syndrome also.
sometimes, whenever
Significant
hypovolemia,
interstitial edema, intravascular volume depletion can produce oliguria.
Yes, ma'am.
Mm. Urine, color of the urine.
Color white. Mother used to notice foam in the urine.
Then it be high colored urine in nephrotic syndrome also.
And dehydration status.
Highly
they can-
concentrated urine may look like a hematuria for the
Yes, ma'am.
patients, isn't it? So you can definitely differentiate these two at the onset of the disease. What about if the patient complains of exertional dyspnea and orthopnea? Will that tells you anything?
What is
Along with this, child developing exertional dyspnea and some amount of orthopnea also. What does that mean? Where is the volume accumulated in this scenario?
maybe gradually backflow and the lungs. She's having cardiac death.
Very simple question.
Very simple.
So you have to just apply your mind and answer this.
At the onset of the disease with this history, complaining of exertional dyspnea and
So
orthopnea.
what is the difference in the fluid accumulation in case of nephrotic syndrome and nephrotic syndrome?
Nephrotic, it is mainly extravascular space, interstitium, and in the nephritic, that is intracellular accumulation will be.
Intracellular,
Intravascular.
intravascular. Okay. So because of that, they develop exertional dyspnea and some orthopnea. So that is also a clue for a possible acute nephritic syndrome there, isn't it?
You said some new drug has been also given?
In the recently last 3 months back, new drug was added, and father
nature you
enabled dose. As per the dose, she is getting twice a day. Probably mycophenolate or tacrolimus, I can think
Which is
of.
more likely, mycophenolate or tacrolimus?
As history of SRNS is there, so I'm thinking in terms of tacrolimus only.
Yeah, more likely to be seen.
Tacrolimus.
So here is the patient who had destroyed resistant nephrotic syndrome. Now, secondary non-responder.
Second. Yes.
Secondary non-responder. So what is the possibility in terms of glomerular disease which is causing this nephrotic syndrome?
One may be inadequate dose, incompliance, genetic.
I am asking about you glomerular disease.
Diagnosis of glomerular disease.
FSGS, diffuse mesangial sclerosis.
Messenger sclerosis?
FSGS
Yes,
probably. MPGN pattern also they can have.
No possibility of MCD.
MCD, rare chances, secondary steroid, only 1% they can have steroid resistant nephrotic syndrome.
Secondary non suppose a patient of the childhood nephrotic syndrome comes, what is the usual course of the disease? Suppose this patient is there in your follow-up, what is expecting, what will be the response, first response, then subsequently how many patients would have the different courses?
From the first presentation, initially, at least definitely 80% people will respond to steroids, and
80%?
80 to 90% they will respond to steroids, minimal change disease.
80 to 90%. Yeah, it is very common dictum. All childhood nephrotic syndrome patients, 90% will respond. Yeah? But more than 90% respond to steroid.
And the rest of the 10%, they can have frequent relapses or infrequent relapses.
They can be from the beginning primary non-responder. What this is called primary non-responder. Okay, fine. So in 90% of the patients in whom you give treatment, what would be the different subsequent courses?
Either they can have frequent relapses or infrequent relapses.
Yes.
Frequent relapses.
Steroid dependence, frequent relapses, infrequent
Infrequent
relapses. Three categories. What is the percentage of these three? Of the 90% who initially responded.
40% will be frequent relapses and 50% will be steroid dependent nephrotic syndrome.
And infrequent?
Infrequent. 90% over.
Not a-
So what happens to the majority?
Majority infrequently relapses.
We have removed that portion. So majority are infrequent relapses. So 40 to 50%, 40-45% patients will have frequent relapses. Then comes the category of the frequent relapses and steroid dependent. And then subsequently
Steroid resistant, second steroid.
secondary non-responders. Out of them, any of the patient of the steroid dependent subsequently becomes secondary non-responders. So, what is the cause of this secondary non-responders?
Genetic causes, monogenic diseases.
Why you are jumping on the genetic? Genetic is the one thing, but if it was the genetic, it would have been the primary non-responders.
Non-LCD, FSGS studies.
So there are 2-3 important things which you should think of. One is the simple transformation of the one kind of the glomerular disease to another kind of the glomerular disease. So that most common transformation in childhood nephrotic syndrome is FSGS, annual change transformation into FSGS. So that is the one histological transformation happens. So that is the one. What else? Any pharmacogenomic aspects of resistance?
But steroid dependent nephrotic syndrome.
Steroid dependent, while patient is on the full dose therapy or while reducing to alternate day regimen, or in spite of after stopping the drug treatment within the 2 weeks of therapy, if patient is getting the
What are
relapse
the
again.
treatment options for
So that is
SDNS?
sufficient. In one episode, say it happens, it is sufficient.
2 episodes, yeah.
At least you have
2
to
continuous
do
relapses.
2 and more episodes.
2 continuous relapses.
That is also important, not a single episode.
So how do you treat SDNS? Steroid dependent?
SDNS, if there is no steroid toxicity, then we can continue with the frequent doses, or otherwise, if requirement of the steroid is more than 1 milligrams per kg, we have to add steroid sparing regimen, either with the MMF or the CMA regimen.
The second line of drugs
Levomisole,
in steroid dependent. Is this straight away MMF?
oral cyclophosphamide, we can try as per the KDIGO, or
Second line is
levomisole.
cyclophosphamide, oral cyclophosphamide for 3 months.
Yeah, levomisole, we can try.
And you have alternatives, but one is preferred over the other. So you have, but you have told directly MMF. MMF is nowhere in the second choice. No one choose this medicine. So look, people should be happy if you tell about the cyclophosphamide, CNI. Many centers prefer CNI over cyclophosphamide. So that is the second. Then only comes this. And fourth one,
And then fourth, rituximab also we can try.
some centers, also using to maintain medication, rituximab. So these are some alternatives. You have for 3-4 alternatives there.
How do you give levomisole?
2 mg per kg on alternate days. 150 mg maximum dose.
How long will you give?
How long? 12 weeks we have to give.
12 weeks.
12 months, ma'am. This one. Government said 12 months.
When you give steroids for inducing a remission in a child, how do you calculate the dose?
Based on the body surface area, that is the preferred method. Body surface area in the initial 4 weeks or 6 weeks course 60 milligrams per meter square per day, or maximum of the 60 milligrams per day. And an alternate day regimen, either we have to give 50 milligrams per meter square per day or 40 milligrams per day.
If you don't want to calculate body surface area, there's a simpler method to do it.
Based on the body weight,
Yeah, so you have the body weight.
2 mg per kg or
Yeah,
1.5
2
mg per kg.
That you should remember, because surface area, who calculates?
You have any, any formula to calculate? surface
Most of
area?
the formulas.
Huh?
Most of the formula.
What is the
Square root of height in centimeters into weight by 3600.
more in
Rough
seven?
guide.
Yeah,
More
you
into
should
weight
say
plus seven,
more in
90
favor
plus
of
weight.
body
And
surface.
weight.
Yeah, pediatricians are more.
Pediatricians is more.
For practical purposes, when you are an adult physician and still you treat children, this 2 milligram per kilogram, this is what even pediatric nephrologists do.
Everyone is
follow.
it's easy to follow,
Yeah.
but definitely you have height weight chart, everything is there, then you can calculate. But there are many formulas prevalent in many centers, so you can calculate. So that's fine.
What is the mechanism of proteinuria in MCD?
Proteinuria. There will be sleep diaphragm membrane protein dysfunction. One is the podocyte loss, podocyte effacement.
Where is the podocyte loss in MCD?
There won't be any loss. Podocyte number will be constant in the MCD. FSGS it will be depleted.
What is the mechanism of proteinuria in MCD?
Unable to recover.
No? So how this protein comes into urine?
MCD, IRC and everything, all these are most basic topics in nephrology.
What substances
A
are
to Z you
filtered
should
through
know.
the glomerulus?
Albumin only predominantly selective proteinuria in this.
Yeah.
Either there will be loss of the
Why there is
anionic
loss
charge.
of albumin?
Loss of anionic charge, like on the podocyte there will
Charge.
be angiopoietin like 4, protein 1, and one more is
Or
podocalcicin.
any
What
permanent
are
is the
the
important things.
molecules which gives the negative charge to the GPM?
Heparin sulfate.
So the size of the
Something like-
molecule and the charge.
Size and charge.
So the two things determine the permeability.
And why there is food process effacement then?
T cell dysregulation one mechanism.
What do you mean by T cell dysregulation?
TH17 more of allergic response.
Food process, what do you mean by food process effacement? Exactly what happens?
It won't cover the entire basement membrane, so there will be some gaps.
No,
That's
no, that is not food process effacement.
Basement membrane kept in side, it will be interdigitating structures.
See,
That is
earlier
not.
this
It becomes
used.
effaced. What do you mean by
There
effaced?
won't be any bridging between the two podocytes.
Loss of food process, simple. Food
Body.
process disappears,
Body.
it becomes
Body.
better.
Juxtaposed.
One continuous
round,
Continuous.
and there won't be any finger
mass of
process.
cytoplasm. Earlier this used to be called food process fusion. So now we know it's not fusion. It's
Why
effacement.
food process are effaced from GPM in MCD?
So do you think this is motile or immotile?
Immotile cells.
Huh? Immotile. What do you mean by motile and immotile food process? Because these are all important conceptually. So see, once the patient go into the remission, all food process again appear. So this is the motility. So when there is disease active, there is effacement, when the patient go into the remission, all food process will reapply. So sometimes findings when you are doing the biopsy, in which stage you are doing, then it is possible.
What do you mean by unsampled FSGS?
If the number of glomeruli is inadequate for the diagnosis of FSGS, but still if there is any tubular inflammation in that histological sample and clinically it is not correlating with the minimal change disease, then we can suspect unsampled
I think it
FSGS
is
in
UPCD, but absolutely could have been.
FSGS
But you know, the sample which you have taken,
and liquid sample.
the focal.
All these pathologists suspect that this is there. It is looking like, many times they write that unsampled FSCs. When, how they suspect, what will be the finding, then you can also suspect, no.
Surrogate markers like interstitial inflammation and tubular atrophy, if it is there, then we can think of it.
On immunofluorescence, do you find anything or is it all negative?
Sometimes very low levels of IgM also we can identify, but if it is predominant, then we can suspect FSGS.
What is Salhab's hypothesis?
Very old.
1972,
Very.
So, Sarah's hypothesis?
What a wonderful, actually how nephrology, understanding of nephrology diseases evolved, that we should know. That may not give us any direct benefit in clinical practice, but that will give us a lot of insight as to how the
आज मैंने
system
morning में
evolved.
पूछा था ये. I have asked this question, whether you should have said that.
Why do these patients undergo relapse following a respiratory infection? Usually, that is a
Usually,
more
Epstein-Barr virus viral illness that will prescribe the
So bacterial respiratory infection, upper respiratory infection.
Not really.
Still बात है, कहाँ से आएगा?
It can be any bacterial or viral infection.
Hospitalized relapse. Why?
Why this happens? How many percentage of the patients could have this upper respiratory?
To understand this, you have to start from Salab's hypothesis. And when he stopped, Salab's hypothesis actually was, the MCD was thought to be a lymphocyte dysfunction. No? Now it is
T-cell mediated.
podocyte disease. So, but still we cannot do away with that. We found a beautiful basis. And we need to know from Salab's hypothesis how we have progressed further and how to link his wonderful observation and the current reality. It was not a podocyte-centric discussion, even during my training.
What is the podocytopathy? Since you're talking about
Podocytopathy. Proteinuria secondary to podocyte loss or glomerular filtration barrier.
Under that heading, what are the disease entities?
Disease.
Podocytopathy is
Minimal change disease, focal segmental glomerular sclerosis, and diffuse mesangial sclerosis, and collapsing glomerular nephropathy.
So all these podocytopathy are different in all categories.
In minimal change disease, there won't be any decrease in the number of the podocytes. In FSGS, there will be decrease in the podocytes. And in the DMS and CPGM, there will be dedifferentiation and proliferation. If it is more of proliferation, then it is CG collapsing. Less proliferation, then DMS.
Can you label diabetic nephropathy as a podocytopathy?
Yes, ma'am. There will be also functionally glomerular filtration barrier dysfunction, so we can.
You should tell me what are the podocyte abnormality described in diabetic nephropathy. Just because of proteinuria, it cannot be a podocytopathy.
Podocytopathy can happen in lupus also. Lupus podocytopathy, diabetic podocytopathy. These four categories we have told us that was limited to some category of development. So, other than that, where podocytopathy can be seen?
SLE1, diabetes.
Lupus podocytopathy, diabetic podocytopathy. In obesity also, you can have some degree of podocytopathy. Obesity related neuropathy. That is, it's a,